Hi, I am Dr. Kanniraj, Orthopedic Surgeon. I specialize in knee, shoulder and hip surgery. Today, we are going to discuss about various graft options available for ACL reconstruction. When someone has got an ACL injury or an ACL tear, we do a surgery where we replace the torn tissue with a new tissue known as the graft. This graft gets converted into ligament by healing in the body within the knee joint by the process known as ligamentization. So, the graft is the tissue that we use to replace the torn ACL. When we do the ACL reconstruction, the graft can be obtained by three different sources. One, synthetic grafts, which is a synthetic substance used to replace the torn ACL. Number two, allograft. Allograft refers to tissue taken from a different person, usually a deceased person, to replace the torn ACL. Number three is autograft. Autograft is the tissue taken from the same individual but from a different site. So, let us see about of these graft options. The synthetic graft is not very popular. Here, what we do is a completely artificial structure is used to replace the torn native ACL. The problem with the use of synthetic graft is that there is a higher rate of mechanical failure as compared to biological graft. Number two, there is a higher risk of infection when using this artificial ligaments as compared to biological ligaments. Number three, frequently use of this artificial ligament leads to repeated swelling and fluid collection within the joint known as knee effusions. 4. With the use of these grafts, we often find that the bone in the leg bone as well as the thigh bone gets destroyed in a process known as osteolysis. So, because of these complications, synthetic graft is not routinely used for ACL reconstruction surgery. Now, newer versions of the synthetic graft are coming to address these concerns. Though there are in the trial stage and few ligaments are currently available for use, they are not available in routine use, and at this stage, synthetic grafts are not routinely used for ACL reconstruction surgeries. The next option is to use the tissue taken from a different person, usually a deceased person, and this tissue is known as the allograft. The advantage of allograft is that it can be used for patients with multi-ligament reconstructions, or it can be used without having to harvest tissue from other part in the same person. But the disadvantage of allograft is basically it is dead tissue. It is not as strong as a biological living tissue. So there is a higher rate of failure with allograft. Allografts are generally not advised in young and active individuals because their strength is low and they are more prone for re-rupture. Now, coming to the third source of graft, that is the autograft, taking tissue from the same individual and using it for reconstruction of the ACL structure. Now, if you see the autograft, the most important thing in considering a tissue for an autograft is that when we take the tissue from a different site, it would not cause any problem or any functional problem from the area from which we are harvesting the graft. So, autograft, the various options available are bone-patellar tendon graft, hamstring tendon graft, quadriceps tendon graft and peroneal tendon graft. The most important characteristics that an autograft should have are the properties of the tissue that we use to reconstruct the ACL should be very similar to that of the normal or native ACL. It should not cause any functional limitation or problem to the area from which we are taking these tissues. This graft should allow secure fixation both in the thigh bone and leg bone during the surgery, and then it should heal rapidly so that the individual is able to go back to their sports and regular life at a quicker rate. So now let us look at each of these grafts in separate. Now, bone-patellar tendon graft refers to taking a piece of bone from the kneecap patella and from the leg bone, the tibial tuberosity. And in between these two bone plugs, we take a portion of the patellar tendon. Patellar tendon is a tissue that connects the patellar kneecap to the leg bone. So, we take a portion of the bone from the kneecap, we take a portion of the bone from the leg bone, and in between these two bone plugs, we take the patellar tendon. So, this is a bone-patellar tendon graft. Now, the next option is the hamstring tendon graft. Hamstring is the tissue that is present in the back of the thigh. They start from the back of the hip, the ischial tuberosity, travel on the back of the thigh and come and attach in the front of the knee joint. What we do is we take a portion of the tendon, the hamstring tendon, semitendinosus and gracilis, and then we fold them to create 4 strands, and then we use this hamstring tendon for ACL reconstruction. Hamstring tendon graft is the most popular tendon graft for ACL reconstruction surgery. When we compare the properties of bone-patellar tendon with that of the hamstring tendon graft to that of the native normal ACL, if we see the load to failure of normal native ACL is 2100 newtons. That is, when you use a force of 2100 newton, the normal ACL will tear. If we look at the graft that we use, for example, the bone-patellar tendon, it has a strength of 2900 newton. So it is higher than the normal ACL. But if you see a quadrupled hamstring tendon graft, it is 4100 newton. That means the load or the force that is required to tear a hamstring tendon graft used for ACL reconstruction is twice the amount of force that is required for a normal ACL. So if you see, both the bone-patellar tendon graft as well as the hamstring tendon graft has higher strength as compared to native ACL, but the bone-patellar tendon is less than that of the hamstring. So hamstring is the strongest tendon graft of these two. Now, if we look at the healing, we place the graft into the bone and then that has to heal and get converted into ligament. The main advantage of a bone-patellar tendon graft is that the bone pieces at the end of the graft heals to the bone in the thigh as well as the leg at a much faster rate. Within 6 to 8 weeks, the healing occurs. That is, within 1 to 2 months, the healing is faster. But if we use a hamstring tendon graft, it might take up to 2 to 3 months for the healing. So, though the hamstring tendon graft has double the strength of the native ACL, it takes longer time to heal as compared to the bone-patellar tendon. So these are the two main differences between the bone-patellar tendon graft and hamstring tendon graft. Now, if we look at the outcomes, how do they fare? If somebody has got an ACL reconstruction with the hamstring graft, somebody has got an ACL reconstruction with the bone-patellar tendon graft. If we look at the stability, both these patients will have similar outcome as far as the stability of the knee is concerned. So whether you use a bone-patellar tendon graft or hamstring tendon graft, the stability you get with the ACL reconstruction surgery is similar. Similarly, their ability to return to sports to the same extent they were playing before the injury, that is also same whether you use a bone-patellar tendon graft or hamstring tendon graft. And then patient reported outcome. These are systems and scores we use to see how good the patient has got better. That outcomes are also similar when we use a bone-patellar tendon graft or hamstring tendon graft. So in short, the stability you get is same. The ability to go back to sports to the pre-injury level is the same. The functional outcome scores, that is also same. So both these bone-patellar tendon and hamstring have similar outcomes. Now, where does the difference lie? The difference, if you look at the 15-year follow-up, you have done an ACL reconstruction in one set of patients with bone-patellar tendon, another set of patients with hamstring tendon. At the end of 15 years, this study shows that they have equal outcomes at 15 years after the surgery. The problems arises in the complications or the donor site morbidity. Bone-patellar tendon graft is known to be associated with a higher incidence of anterior knee pain. Anterior knee pain refers to the pain the individuals feel in the front of the knee. There is a vague discomfort or pain they feel in the knee after ACL reconstruction surgery. This anterior knee pain is very high when we use bone-patellar tendon graft for ACL reconstruction. So this is one of the articles published in the Journal of American Academy of Orthopedic Surgery. This study shows that in people who need to kneel down either for profession or for sports, for example, car mechanic, plumbers or wrestlers who have to bend down and kneel, for these individuals, bone-patellar tendon has to be avoided because of the higher incidence of anterior knee pain. This is another article from scientists based in Japan, Canada and Italy. This study clearly states that the anterior knee pain or the donor site morbidity is very high with bone-patellar tendon graft because it causes extension, the quadriceps muscle weakness, and it has to be avoided in people who have to do kneeling either for praying purpose or for sporting or for employment. In these patients, bone-patellar tendon is to be avoided. So from this, it is evident that the anterior knee pain is a major problem with bone-patellar tendon graft, particularly if you have to do regular kneeling on a daily basis. Now, the other complications associated with the use of bone-patellar tendon include patellar fractures. Because the kneecap is a relatively smaller bone, if you are going to take a piece of bone from it, there is a small risk of fracture of the kneecap, either during the surgery intraoperatively or after the surgery during the rehab and once they return to the sports, because a small portion of the bone has been taken from the patellar bone. The other risk is there is a small chance of rupture of the patellar tendon because we are taking the central 1/3 of the patellar tendon, and then when we are doing a forceful shooting of the ball during a football or any other injury, there is a small risk of patellar tendon rupture with the use of bone-patellar tendon. Similarly, there can be some inflammation, and long-term studies have shown that use of a bone-patellar tendon is associated with higher incidence of arthritis in the knee as compared to hamstring tendon graft. So these are the risk factors associated with the use of bone-patellar tendon. One, pain in the front of the knee. There is a small risk of fracture of the patellar kneecap. There is a small risk of rupture of the patellar tendon, and then inflammation of the patellar tendon, patellar tendinitis, and arthritis of the knee joint. Now, if you look at the complications or risks with the use of the hamstring tendon graft, the main risk is we are not able to predict the size of the graft that we will get. For example, we are taking a portion of the hamstring tendon and then we are folding it into 4 strands. If you see, we have to measure the size. The size for a successful ACL reconstruction, according to all the studies, it has to be 8 or more. In Asian studies, we accept 7.5 as the minimum diameter that we need to use. Because when we use a smaller diameter graft, the risk of rupture of the reconstructed ACL is high. So you should have a thick graft when we do an ACL reconstruction. With the use of hamstring, the problem is that sometimes the tendons are very thin. Even after making 4 strands, sometimes what we find is the thickness is very less. So that is one of the issues with the use of the hamstring tendon. The other issue is, as I told you before, in the bone-patellar tendon graft, the bone-to-bone healing is much quicker, whereas in hamstring, the tissue has to heal to the bone, so that is relatively slower. So these are the risk factors with the use of hamstring tendon graft. So how do we manage that? For example, when somebody has got a small graft diameter, how do we do that? Normally, we fold the graft into 2. That is like 2 graft we are using, and we fold each into 2. So for total 4 strand. Now what we do is, rather than folding it into 2, we fold it into 3. That is called as tripling of the graft. Rather than folding it 2 times, we fold it 3 times so that we make a tripled graft. By doing this, we are able to increase the diameter of the graft. The other option is to make it into 4. Like you got a graft, instead of folding it into 2 or 3, you fold it into 4 and then use it. This we do by a procedure called as a all inside ACL reconstruction. Here we use a button on the thigh bone, button on the leg bone, and without using any screw, we do this fixation. That is an all inside ACL reconstruction. The third thing is we can augment it. In addition to using the graft, we use a fiber tape. Fiber tape provides additional stability to the graft, so that when we have a little less diameter, we can use a fiber tape. So these are the ways by which we can increase the diameter of the graft so that the graft is strong enough for the ACL surgery. Now, the third commonly used graft is the peroneus longus graft. Peroneus longus graft is a tissue that is taken from the outer side of the ankle. We have 2 tendons, peroneus longus and peroneus brevis. What we do is we take a portion of the peroneus longus tendon and then we use it for ACL reconstruction. Now, several studies have shown that use of a peroneus longus graft results in a much thicker graft. So, you will get a good diameter of the graft, and then it produces good functional outcome and then stability to the knee and return to sports. So peroneus longus graft is the other commonly used graft. It does not cause any functional problem in the ankle from where we are taking the graft. Now, in summary, if you look at the graft option, hamstring tendon graft is the most commonly used graft for ACL reconstruction because it does not have any major problem seen with the bone-patellar tendon graft, and then it gives good functional outcome, stability, and return to sports. The second preferred graft is the peroneus longus tendon graft, particularly when you are expecting that the hamstring tendon diameter is going to be small. This is very common in female who are relatively short statured. In these individuals, when we expect that the graft diameter is going to be small, their peroneal longus tendon is a very useful graft. Second, when we are using a multi-ligament injury where you need multiple graft, then peroneus longus tendon is preferred. Similarly, when there is a revision ACL, when they have done a surgery, then they have ruptured the graft and then we have to do a revision surgery, there also peroneus longus graft is a very, very valuable graft. Bone-patellar tendon we use primarily for revision ACL reconstruction. Somebody has got an ACL and ruptured the graft and then they want to do a revision. There we consider a bone-patellar tendon graft. And then this should be considered, explaining the risk that there can be a significant proportion of patients who might get anterior knee pain with kneeling with the use of bone-patellar tendon graft. So in summary, the most commonly used graft is autograft, that is the tissue taken from the same individual's body, and out of that the three commonly used ones are the hamstring tendon graft that gives a good functional outcome and then stability. Second is the bone-patellar tendon graft. There is a small risk of anterior knee pain, patellar fracture, rupture of the patellar tendon and arthritis in the long term. Third is the peroneus longus graft. In addition to these three, we can also use the quadriceps tendon. That is, the quadriceps is the muscle in the front of the thigh. We can take a portion of the quadriceps tendon either with or without a bone plug from the kneecap, and that can also be used for the ACL reconstruction surgery. Thank you.